12-year-old boy presented with a bamboo stick injury. It was a straight injury hitting the cornea at this point, and the bamboo had penetrated all the way and hit the lens as well. There was no iris involvement, and the AC was moderately shallow. Now the surgery has been planned. The plan is for a corneal tear suturing with a 10-0 nylon, form the AC and then approach the lens. Well, then the thinking was how to approach the lens. Should it be a nasal approach or should this be a superior approach? As you can see, the capsular margin has torn vertically. So if I have a nasal approach, a nick here would be possible, and to get a good rhexis with a utrata would be possible, but I couldn't think of a way to get a nick on this side of the capsule. But if I have a superior approach, I can approach and have a good cut or a good nick both on the nasal capsule as well as the temporal part of the capsule. Under general anesthesia, the child was approached superiorly. First, little air was injected to form the AC a bit, and then a little bit of visco was injected into the anterior chamber. The wound was then washed with normal saline. Fragments of bamboo were washed off. Once a clean wound is ensured, 10-0 nylon was used to suture the wounds. 3 bites were taken and sutured. Anterior chamber is approached by a corneal incision. The first nick on the capsule is made with a 20 gauge retinal scissors. The rhexis is then extended with a utrata forceps. And this has been the area that had been nicked by the 20 gauge retinal scissors and then further extended with the utrata to make another nick here and then complete this as well. But then I decided against it because this was a very poor patient, and taking him up for a second procedure would be unbearable for him. So hence I thought the benefit of placing an IOL at the same time would save him some money. This part of the capsule intact, I wouldn't remove it and just stay on with this opening in the anterior capsule. The IOL being planned, if the optic needs a good support anteriorly, I thought this may be the adequate size of the anterior capsule opening. Then the nucleus was removed by using irrigation and aspiration. This is slow aspiration and irrigation, ensuring that the capsule is never caught in between. Then the IA ports are exchanged and the temporal half of the cataractous lens is removed patiently. Next challenge is to place an IOL. So I plan to place a foldable acrylic in the bag placement. The lens was then dialed into the bag. Ensure a good centration of the lens. The excess visco is then aspirated and AC is formed with air. The side ports and the tunnels are sutured. Postoperative day 1 pictures with a clear cornea and a well formed AC and a shining intraocular lens inside.